Good morning to all of you. A warm welcome to our Zoom webinar organized by Government Medical Officers Association and Sri Knowledge Academy. Today there will be 2 lectures and our topics are going to be on life-threatening medical emergencies, not to be missed by a doctor, and approach to common medical emergencies in emergency department. Before we start, I would like to thank Dr. Indika Lenarol, Consultant Emergency Physician at National Hospital Sri Lanka, and Dr. Nandana Jayatilaka, Consultant Emergency Physician at Teaching Hospital Peradeniya for coordinating this program. Kindly mute your microphones and your cameras during the presentation and use the chat box to clear your doubts at the end of every session. Now it's my pleasure to introduce our first speaker, Dr. Tushara Vidanapathirana, Consultant Emergency Physician currently attached to District General Hospital, Mathura, and his lecture is going to be on life-threatening emergencies not to be missed by a doctor. Over to you, sir.
Thank you very much for your kind introduction. So, good morning, everybody. My name is Tushara Vidanapathirana, Consultant Emergency Physician attached to District General Hospital, Mathura. Today, I'm going to discuss a few important emergencies with higher possibility of missing by doctors, and I want to give you attention particularly on these emergencies if it presented to you as a first contact person. So most of I don't have any conflict of interest. Most of you all are working as general practitioners, and others are working at other trainee positions. So if generally, if patient presented to you, if you missed this kind of diagnosis, and if patient ended up with devastating consequences, you may need to face a lot of issues. So first thing is impact on patient, other thing is effect on your GP practice, or this may be highlighted in social media, which may create bad image on you. So therefore, I wanted to highlight these specific topics for you all. I'm not going for a conventional presentation. I'm going to discuss few cases presented to me. The first case I'm going to discuss is a 33 years old patient presented with urinary incontinence while at sleep. Mother noted noisy breathing when he was at bed. He was rigid. Complaint of tongue bite late, and once he regained the consciousness, and he was fully conscious at the time of presentation to me. He was very well before going to bed. No significant past medical history, no alcohol or drug use. His clinical examination was unremarkable. This is a very common presentation come to you. Being emergency physicians, we are always looking at these sort of cases in open-minded way, rather than focusing into a specific particular diagnosis. We are thinking in a way that what could be the worst possible thing that can happen to this patient. So in case, if this kind of patient comes to you, you need to investigate and need to plan patient's management. Once patient comes to emergency department, we need to think whether this patient can send home. If not, whether this patient needs admission. If so, which unit this patient belongs. From the emergency department, this patient should be directed to the right specialty. Otherwise, their proper management may get delayed. Basically, if this kind of patient comes, we'll do routine blood investigation, full blood count, electrolytes, and all. This is obvious according to the history that this is a seizure attack. Our traditional approach is, we'll do basic blood investigation. If this kind of patient comes to emergency department, we'll do a venous blood gas to see whether there's any correctable causes. And in addition to that, this is a first episode of seizures. Most of us definitely proceed with a CT brain to exclude possible intracranial pathology. This patient, in addition to that, we'll do a ECG. So this patient's talking and he was well looking. So we did a ECG. Yeah, this is the ECG. I'll give you a few seconds to go through the ECG. The conventional practice was to admit this patient to a medical ward or a neurology unit. Can somebody post what could be the ECG? What could be the ECG findings? Basics are basics. Which level you are practicing? Yes. Fasika has given an answer exactly correct. This is a Brugada type ECG, which should not be missed by a medical officer. ECG basics, basically you need to look at the ECG, confirm patient's identity, then you need to look at the heart rate, ECG rhythm, axis, P waves, QRS complexes, and T waves, and specific intervals, and you need to look for is there any specific abnormal waves present in the ECG. These are the basic approach into any kind of ECG. So here, in case we got the clear diagnosis from one of the doctor, this is a Brugada type ECG. So Brugada syndrome diagnosis is mainly depend on characteristic ECG findings and clinical criteria. Brugada syndrome is first discovered in 1992 by Brugada brothers, and it's a genetical disorder running in families due to sodium channel mutation. The mean age of presentation is 41 years, but there are reported cases from 2 days to age 84. So this is the characteristic Brugada sign in ECG. You can see lead V1 and V2, right curved ST segment elevation more than 2 millimeters of V1 to V3 followed by a negative T wave pattern. This doesn't confirm Brugada syndrome, but it's a potentially diagnostic of Brugada syndrome. What happened if you miss this during presentations? Sometimes this patient may not come to us again. Sometimes we'll get the dead body if he develop dangerous cardiac arrhythmia. That is the Brugada type 1. Brugada has describes in 3 types. Brugada type 2 described as ST segment elevation with more than 2 millimeters with saddleback pattern. You can clearly see that there's a saddleback pattern. If this is present, this is type 2 Brugada pattern ECG. Then the type 3 is described as either type 1, that means curved ST segment elevations with T wave inversion, or saddleback appearance is more than 2 millimeter ST segment elevation, that pattern. But in type 3, it could be either, but height is less than 2 millimeter. Height is less than 2 millimeter of the ST segment. So ECG changes can be transient with Brugada syndrome and can also be unmasked or augmented by multiple factors. If these changes, most of the time these changes may present with fever, myocardial ischemia, use of multiple medications, hypokalemia, hypothermia, or even post-DC cardioversion also. These sign can be appeared. Brugada sign in isolation is a questionable significance. ECG abnormality must be associated with one of the following clinical criteria to make the diagnosis. If there's documented ventricular fibrillation or polymorphic ventricular tachycardia, if there's a history of polymorphic ventricular tachycardia, or family history of sudden cardiac death at age less than 45 years of age, or curve type ECGs in family members, inducible VT with programmed electrical stimulation, which should be done in a cath lab, or a patient may present with syncope or nocturnal agonal respiration. If these ECG findings combined with one of these, then can come to a diagnosis that this patient is having Brugada syndrome. In these patients, as I told you from the beginning, we were open-minded. We wanted to exclude subarachnoid hemorrhage, intracranial bleeding, so we did a CT brain. It was normal, and we further got advice from a neurologist. EEG was normal, and this patient was referred to electrophysiologist for further management and diagnosis. I think you all make clear about Brugada syndrome. I hope you will never miss if you get this kind of presentation in future. Then I'm moving to the case 2. 36-year-old male Sri Lankan living in Australia returned home country for surgery and further management of his recently diagnosed bowel cancer. While he was investigating as outpatient, 1 week later developed chest pain and mild shortness of breath. He was seen by family doctor. He had suspicious ECGs and directed to District General Hospital. His troponin was positive and treated with enoxaparin for 3 days with diagnosis of non-STEMI and discharged home. 3 weeks later, he developed severe chest pain and shortness of breath. On arrival to hospital, found dead. What have we missed? We went through the postmortem findings. The concern is, does all chest pain is MI? If we exclude MI, are they safe? As I told you from the beginning, we should be open-minded and we need to think in the way of possible worst possibilities. If we can rule out these all worst possibilities, we can rule out dangerous presentations, and then we can do a safe discharge even from the emergency department. I can see that I'm getting a correct response from you all into chat box. This is the ECG pattern what we saw in these patients. We could see classic S1 Q3 T3 pattern with right bundle branch block. Actually, this patient's postmortem findings was pulmonary embolism. It was a massive pulmonary embolism. This patient had a lot of risk factors. Pulmonary embolism is not come to the screen and we are not giving much contribution, much suspicion on pulmonary embolism. Most of the time it's underdiagnosed. So if we go through the classic ECG findings of pulmonary embolism, 44% may have sinus tachycardia. They may have a complete or incomplete right bundle branch block. Then right ventricular strain pattern, right axis deviation, dominant R wave in V1, right atrial enlargement, S1 Q3 T3 pattern, which is very common, and if we ask what is ECG findings, this is the answer what we are giving, but we can see it only among 20% of patients. 20% of patients. Due to the change of the cardiac position, clockwise rotation can be seen. They can present with cardiac arrhythmia. The most interesting, they may have completely normal ECG in 18% of patients. So, in this case, this patient came with a chest pain with a lot of non-specific ECG changes. Troponin is positive. The diagnosis is directed toward non-STEMI. During hospital stay, this is not a massive pulmonary embolism. This patient got a cover with enoxaparin, but patient never had anticoagulation. So this patient again presented with massive pulmonary embolism and died. Always we need to be open-minded. Being troponin positive, it's not. Heart attack is not the only cause to become troponin positive. So they can have myocardial infarction in case troponin can become positive. So it could be type 1 due to atheromatous plaque rupture, or type 2 myocardial infarction. Extreme hypertension, anemia, vasospasm can cause type 2 myocardial infarctions while they are having normal coronary arteries. So there are a lot of other causes for positive troponin, acute and chronic heart failure, myocarditis, cardiac contusion from trauma, cardioversion, aortic dissection, hypertrophic cardiomyopathy, and a lot more causes for positive troponin. These are the cardiac causes. But there are a lot of other non-cardiac causes also for positive troponin, which include renal failure, pulmonary embolism, severe pulmonary hypertension, sepsis, severe critical illness, burns, even extreme exertion can cause raised troponin levels, stroke, even subarachnoid hemorrhage. Also, patient can get elevated troponin levels. When interpreting a context of this sort of background, you have to be very careful whether it's a myocardial infarction or not. So the most important thing in patient management is the history. You need to take detailed history. It's obvious that this patient had a long haul air journey. Roughly, it will take about 10 hours to 10. It could be a 10 hours air travel to Sri Lanka. This patient had an underlying malignancy. Those are high risk factors for pulmonary embolism. The gold standard test to confirm pulmonary embolism is CT pulmonary angiogram, but in our setting it's difficult. But when I was practicing overseas, if we suspect pulmonary embolism, straight away patient is going to CT room, no steroid process, straight away they are doing CT pulmonary angiogram while giving contrast, and we can confirm diagnosis then and there. If diagnosis is delayed, patient may end up with devastating consequences. Always risk stratification is very must. For imaging and other diagnosis, you can use diagnostic tools, which is I'm not going to describe. So common diagnostic criteria we are using is Wells criteria and PER criteria. This is just this is just an eye-opening discussion on pulmonary embolism. I expect you all to read around this, how to diagnose and how to rule out pulmonary embolism criteria and when to go for imaging. You need to read and understand this. So the next case 3. 46 years old female presented with GP with fever, severe pain and rash on her left foot. She has a history of type 2 diabetes mellitus. GP diagnosed cellulitis, started coamoxiclav, paracetamol, famotidine and some other unknown tablets. We couldn't find what are the tablets. This was her foot. You can clearly see that it is reddish, swollen, and I felt it warm. And patient had excruciating pain compared to the lesion over her foot. This patient went home and this patient with antibiotics, and early morning this patient was admitted to hospital. Patient was tachypneic, hypotensive, acidotic. We did vigorous fluid resuscitation, ICU admissions, multiple surgeries, prolonged hospital stay, rehabilitation, and sent home after about 3 months. What could be the diagnosis? It's not erysipelas. If it is erysipelas, obvious this is a sepsis. This is obvious sepsis. Exactly, this is necrotizing fasciitis, neck fasc. This is after wound toilet. She got this much wound debridement. So diagnosis was necrotizing fasciitis. The classic feature is necrotizing fasciitis, patients coming with excruciating pain compared to the redness in their foot. It's an unbearable severe pain. And other thing is, according to you need to assess the risk factors. You need to have a high degree of suspicion. Necrotizing fasciitis is common among immunosuppressed patients. Those who are having chronic kidney disease, diabetes, on immunosuppressive therapy, it's very common among them. This is rapidly progressive disease. Usually this is polymicrobial. You need sepsis kills patient, so you need to have a diagnosis early. These patients need early vigorous antibiotic treatment to control disease spread, and if extensive tissue necrosis is there, patient need wound debridement. At presentation, sometimes you may feel crepitations due to underlying gas formation inside the tissues. If you use ultrasound, you may see gas among tissue planes, or if you do a CT, you can clearly see gas bubbles among tissue planes. They need empiric treatment. So antibiotic of choice is meropenem and clindamycin. You need to take blood culture and all formal septic shock sepsis management. And don't delay antibiotic. You need to give early antibiotics. What our practice is, if patient comes with cellulitis, we'll mark the area with a permanent marker and observe whether this cellulitis, the redness is spreading beyond the marker lines towards the other area very rapidly. Within 4 hours, if it is rapidly spreading, we'll take this as necrotizing fasciitis and we'll admit this patient. we'll treat them with strong antibiotics, and they need vigorous antibiotic treatment. So even with appropriate antibiotic therapy, their mortality is around 30 to 40%. So then I'm moving to case number 4. So 17 years old boy awaiting school marathon presented to GP with ECG to assess fitness for the marathon. ECG seen by the GP and said he is apparently well fit for marathon. At the 5th kilometer, post child collapse found dead by paramedics. What happened? This is the ECG. Yes, Dr. Akandawala, it's clear this is a case of cardiomyopathy. This kind of you should not miss this kind of diagnosis. You should be aware of classic ECG findings of cardiomyopathy, hypertrophic cardiomyopathy. So if you go through the ECG, you can clearly see that left ventricular hypertrophy, R wave height is V6 R wave height plus V1 S wave height is exceeding more than 5 large squares, confirm left ventricular hypertrophy. Then you can see Brega-like Q waves in inferior leads and lateral leads. So these Q waves are different from infarcted Q waves. Typically, they are more than 40 milliseconds infarcted ones, but septal Q waves in HOCM are less than 40 milliseconds. They can have P mitrale, or the reason for death is cardiac precipitation of arrhythmia like atrial fibrillation, supraventricular tachycardia, or ventricular tachycardia. So if you come across an ECG like this, never miss hypertrophic obstructive cardiomyopathy, especially young people. This is one of the common cause for sudden death in young people. Other causes are arrhythmogenic right ventricular arrhythmia and Brugada syndrome. I suggest you all to read about arrhythmogenic right ventricular rhythm, which is also a very important diagnosis to prevent sudden cardiac death in. So exertional syncope, or they are presenting with symptoms of pre-syncope. Symptoms of pulmonary, they may have symptoms of pulmonary congestion. They are coming with chest pain and palpitation. So in this case, diagnosis is hypertrophic obstructive cardiomyopathy. I'm moving to the case number 5. 64-year-old male patient with a history of bowel cancer presented with generalized malaise and lethargy. He had chemotherapy 5 days ago. GP prescribed paracetamol, augmentin, and pantoprazole, and some more white tablets. We couldn't find what they are. Early morning, patient was admitted with hypotension and reduced GCS, managed as septic shock according to the surviving sepsis guideline, with 3 inotropes to maintain MAP of 65. This patient was admitted to ICU, found to have absolute neutrophil count of 300. This is a case of neutropenic sepsis where patient can die within hours. Neutropenic sepsis, also called febrile neutropenia, is defined as a single temperature measurement of more than 35 centigrade or a sustained temperature of more than 38 centigrade for more than 1 hour in a patient with a decreased absolute neutrophil count less than 500. Sometimes immunosuppressed patients may present without fever. These patients' managements are time-critical management. Risk factors for febrile neutropenia are post-chemotherapy, post-transplantation, chronic granulomatous disease, even clozapine-induced granulocytosis also patients also can go into febrile neutropenia. Neutropenic patients are at extreme risk of going into septic shock and death. Do not neglect that these patients are having a malignancy and they are ready to die. They are getting treatment with variable prognosis. So in case treating doctors, we should deviate from prejudice and we need to look after these people. Especially those who had chemotherapy, they are at a greater chance of going into febrile neutropenia. It's a time critical management. You need to give IV antibiotics. You need to follow surviving sepsis guideline management criteria, and they need early antibiotic treatment. Empirical antibiotic choice is piperacillin and tazobactam. Before antibiotics, you need to take blood cultures. In case if it is delaying more than 5 minutes, you better start antibiotics before blood cultures. They need reverse barrier nursing. What reverse barrier nursing is, we need to prevent patient getting infection from us, not from patient to healthcare worker. Patient can get infections from healthcare workers. Therefore, ideally these kind of patients should be managed in a positive pressure isolation room for the safety of the patients. Always, if patient with a malignancy or post chemotherapy coming with generalized malaise, even without fever, you need to strongly suspect possible neutropenic sepsis. Till blood count available, you need to start antibiotics. If blood count comes as less than 500, you need to treat as neutropenic sepsis. But if white cell neutrophil count is more than 500, then you need to act accordingly. You can get rid of the diagnosis of neutropenic sepsis. So I'm moving to my final case. These days, vaccination campaigns are very common. You are facing these kind of cases. You need to be up to date on management of these kind of cases. So this case is 56-year-old previously healthy female suddenly collapsed at salon while using hair dye. It's obvious. Yes, I'm getting a lot of answers. On admission to emergency department, she had gasping bleeding with blood pressure of 60/40, pulse rate 130, hardly any air entry on both lung field with oxygen saturation of 76. She had warm peripheries with flushed appearance. It's clear that all doctors can diagnose anaphylaxis. No doubt this is a clearly case of anaphylaxis. So even though we have diagnosed anaphylaxis, we need to strictly adhere to the diagnostic criteria. In this case, I wanted to highlight how it differs from allergic reaction and the definition of anaphylactic reaction. What is anaphylaxis? Anaphylaxis is highly likely when any one of the following three criteria are fulfilled. I'm going to describe one by one these criteria. So, acute onset of an illness, minutes to several hours, with involvement of the skin, mucosal tissues, or both. This could be generalized hives, pruritus, flushing, swollen lip and tongue uvula, and at least one of the following: respiratory compromise, reduced blood pressure or associated symptoms of end-organ dysfunction. That means hypotonia, syncope, or incontinence. If patient with onset of acute illness with involvement of skin, mucosal tissues with respiratory compromise or reduced blood pressure, we will take this as anaphylaxis. Other set of criteria, two or more of the following that occur rapidly after exposure to likely allergen: involvement of skin mucosal tissues, respiratory compromise, reduced blood pressure or associated symptoms. In this case, patient has fulfilled all criteria. So hair dye is well known that a lot of people died after exposure to hair dye. Non-allergen is there. Respiratory compromise was there, even hypotension also there. Then this case is clearly, according to definition, it's a clearly anaphylaxis. Then the third criteria is reduced blood pressure after exposure to non-allergen. Those who are allergic, if accidentally got penicillin injection, drop blood pressure, it's anaphylaxis. Infant and children, if they present their low blood pressure defined for their age, if it is greater than 30% decrease in systolic, we consider these infants are hypotensive. For adults, systolic blood pressure less than 90 or greater than 30% decrease from that person's baseline blood pressure. Sometimes they may have uncontrolled elevated high blood pressures. If their blood pressure is low from 30% from the baseline, we'll take their hypotensive. These are the three criteria described to diagnose anaphylaxis. So those who are having anaphylaxis, fatality can occur within minutes if a patient stands, walk, or sit suddenly. Patient must not walk or stand even if they appear to have recovered. So these are the correct position. If patient is having a respiratory compromise, While patient maintaining normal blood pressure, you can keep patient like this, but if they are hypotensive, patient should lie flat to maintain vital organ perfusion. If baby is if a baby is having anaphylaxis, they should not keep in upright position on shoulder. The baby should lie flat. If patient is vomiting and risk of aspiration, even you can keep them in left lateral position. Do not, the important message is, do not keep them stand, may end up with devastating outcome. So structured approach for any emergency is necessary. Structured ABCD approach. Always we are telling this mantra, but bit reluctant to follow this approach. Why we are following this approach ABCD? That we need to address killing things first. So if patient is still with the allergen, you need to remove. For example, wasp attack, you need to remove all the stings. Emergencies cannot manage alone. Always you need to work as a team. In emergency department, we are doing we are having pre-allocated roles for the staff, like resuscitation doctor, airway nurse, circulation nurse. If we are getting emergency, this team is involved in resuscitation with pre-allocated roles. So if your patient is having anaphylaxis, this patient need to lay flat. Do not allow them to stand or walk. Do not hold infant upright. If breathing difficulty, allow them to sit. So anaphylaxis, first line treatment is adrenaline. First line treatment is adrenaline. You don't have time to speak to your seniors. You don't have time to speak to your consultants. You need to manage then and there. You need to give adrenaline. First line treatment is adrenaline. So adrenaline dose must be at your fingertips. All doctors should remember this adrenaline dose. We are giving adrenaline 1 in 1000, 0.5 ml. We can go up to 3 doses of adrenaline intramuscularly. This can be given into the lateral aspect of the mid-thigh. Pediatric dose is 1 in 1000, 0.01 ml per kg, maximum 0.5 ml. So this is very easy to remember. All Sri Lanka adrenaline vials comes in 1 in 1000. Each vial contain 1 ml. So what you need to do is break the vial, get the half vial. If you have difficulty in remembering numbers, break the vial, get the half of the vial and give it intramuscularly if you suspect anaphylaxis. Delay the treatment, worse outcome. So if patient is having, you need to have obvious 2 wide bore cannula when you are at the level of assessing circulation. You need to give IV fluid. Choice of fluid is 0.9% saline. You can give 20 ml per kg or maximum 50 ml per kg within 30 minutes if patient is not responding to adrenaline. So for an adult, you can go up to 3 liters if they are not having any other comorbid diseases. If no improvement after 3 doses of IM adrenaline, you need to go for adrenaline infusion. It is easy to remember. In other countries, what they are describing is 1 vial into 1 liter of saline. Our salines come in 500 ml, so you need to give half vial of adrenaline. Need to mix with 500 ml of saline. You can titrate this 5 ml per kg per hour. Then patient is getting 0.1 micrograms per kg per minute. This is easy to remember. Half vial into 1 pint of saline. Starting dose is 5 ml per kg per hour. You need to titrate adrenaline infusion according to the response. The problem with this infusion is you are giving diluted large volume. They may end up with fluid overload. So to prevent fluid overload, you need to set up a proper adrenaline infusion. This 0.5 ml in 500 ml of saline is set up for pre-hospital care or in a situation where if you are not having infusion pumps. But if you are having infusion pump, you can give concentrated adrenaline infusion. The protocol for 100 ml of normal saline is as follows. So you need to mix 1 ml of 1 in 1000 adrenaline. That means 1 vial into 100 ml of normal saline. Initial rate adjusted accordingly to 0.5 ml per kg per hour. If you are giving 0.5 ml, so patient is getting 1 micrograms per kg per minute. Should only be given by infusion pump, not by the burette sets. This is how you prepare adrenaline infusion if your patient is not responding to 3 intramuscular doses of adrenaline. So there are additional measures to consider if your patient, if adrenaline infusion is ineffective, so patient may present with stridor, airway features of airway obstruction. You need to nebulize with adrenaline, pure adrenaline. You need to take 5 vials of adrenaline and nebulize with adrenaline, which may relieve upper airway obstruction. For persistent hypotension or shock, you can give fluid up to 50 ml per kg 50 ml per kg. You need to load it within 30 minutes. So you need to give fast fluid. You need to resuscitate this patient very fast. So persistent wheeze. They may have very tight lungs, so you need to use bronchodilators. You can use salbutamol puffers, especially these patients we are getting suspected or undiagnosed COVID patients. In those sort of a situation, rather than the nebulization, if you can give salbutamol puffers with MDI, patient you need to prescribe 12 puffs of 100 microgram salbutamol. Or you need to nebulize patients with 5 milligram of salbutamol mixed with saline. So 12 puff of salbutamol MDI is equal to a single nebulization. You can use corticosteroids. You should give oral prednisolone 1 milligram per kg, maximum up to 50 milligram, or intravenous hydrocortisone 5 milligram per kg, maximum 200. I have seen a lot of people are giving 100 milligram. 400 milligram, but desired dose is 200 milligram is sufficient. In patient with cardiogenic shock, especially if taking beta blockers, consider an intravenous glucagon bolus. This is most of the time this is not available in our hospital setup. If it is available, you need to use glucagon initially 1 to 2 milligram for adult and 20 to 30 microgram per kg up to 1 milligram in children. This may be repeated or followed by an infusion 1 to 2 milligram per hour in adults. In adults, in adults we can use selective vasoconstrictors like metronidazole or vasopressin only after advice from emergency medicine consultant or critical care specialist. Metronidazole dose is 10 microgram per kg dose can be used to constrict their vessels. Caution: intravenous boluses of adrenaline is not recommended due to risk of cardiac ischemia or arrhythmia unless the patient is in cardiac arrest. IM adrenaline would be the best thing for anaphylaxis. But there's a IV adrenaline. I have seen people use IV adrenaline, but you have to be very careful. The recommendation is IM adrenaline for anaphylaxis. No direct IV adrenaline boluses, because undiluted higher dose of adrenaline may lead to cardiac arrhythmia. So antihistamines. Antihistamines have no role in treating or preventing respiratory or cardiovascular systems of anaphylaxis. Do not use oral sedating antihistamine as side effects mimic signs of deteriorating anaphylaxis. Injectable promethazine, earlier we used, it's no longer recommended. Patient may develop drowsiness and sometimes intramuscular, sometimes cases of muscle necrosis has been reported. So corticosteroids, the benefit of corticosteroids in anaphylaxis is unproven. There's no proven benefit, but it's in the guideline. So the other important component is disposition. Those who got adrenaline, we need to monitor minimum for 4 hours in the emergency department. And those who got multiple doses of adrenaline cannot be discharged from the emergency department. They need to be observed for overnight in the hospital because they can get a biphasic type of anaphylactic reactions. Therefore, they need to be closely monitored during their hospital stay. So I have discussed 6 cases. I believe that you may got a sound idea of common the emergencies which present to emergency department with possibilities of missing or misdiagnosis. Um, so I have discussed these cases to highlight what you need to give attention, and due to limitation of time, I have discussed few cases superficially, so you need to read around these cases. Uh, I got few questions into the chat box. Pediatric patients also you need to give adrenaline IM. IV adrenaline boluses are not recommended. I mentioned, and if you need to use IV adrenaline infusion if patient is not responding to 3 adrenaline IM injections. One doctor is asking, is it safe giving IM adrenaline following AVS or snake bite because risk of hematoma? But we can manage hematoma. First thing is the life. If anaphylaxis management is delayed, patient may die. So first thing is life rather than the limb or the wherever the place you are going to save. If patient is going into anaphylaxis, better you need to go ahead with adrenaline rather than thinking of hematoma. Later we can, if it is infected or whatever, we can manage those things. First thing you need to save the life. I think one doctor is asking whether it's possible to get a video of this lecture. You need to contact Sri office and verify from them. I think they are recording this lecture. Another doctor is asking for a viper bite. Of course, anyway, we need to give IEM rather than thinking about hematoma, because this is a life-saving thing. Especially in peripheral settings, adrenaline boluses are not recommended. This is the latest guideline practice in Australia. One doctor is asking whether there's a specific method to diagnose necrotizing fasciitis. Specific method, there are no specific investigation. It's a history and examination is very important. The classic feature is they are getting excruciating pain compared to the redness of the skin. Sometimes you may feel gas under tissue planes. And this is very rapidly spreading. If you mark it with a marker, it very quickly it crosses borders and spread very rapidly. Yes, well, is there any role of vasopressin? You need to go with metreminol or vasopressin with the consultation of either emergency physician or critical care expert. Resistance cases, of course, you can use vasopressin. One doctor is asking why prefer thigh rather than the deltoid. In pediatrics, better sometimes they are having very small muscle mass. Therefore, thigh would be preferred using. But general recommendation is you need to give intramuscular injection. Another doctor is asking, still antibiotic test dose are given. So during my overseas practice, no penicillin sensitivity was observed. We'll get patient's history, whether you are allergic to this medication. If patient is allergic, we don't give. If patient is not allergic, straight away we'll give antibiotic. If patient develop anaphylaxis, we cannot predict. So if patient develop anaphylaxis, we'll manage them. And anaphylaxis is not dose dependent. Even a test dose is sufficient to develop anaphylaxis. There are a lot of reported cases of anaphylaxis after giving a test dose. Another doctor is asking whether it's take more than 24 hours to develop anaphylaxis. General consensus is less than 24 hours, but those are observation, but extreme cases may present. It's a difficult question and cannot give answer. Sometimes they may present. Most of the medications and things get absorbed less than 24 hours time, and if they are developing anaphylaxis, most of the time they develop. anaphylaxis, but I'm not sure. I didn't find any case report anaphylaxis developed after 24 hours. Is it recommended to give multiple doses of adrenaline in field practice? Wherever the place you need to save the life. In case you need to give 3 doses of adrenaline to see if your patient is not responding. So I described you that pre-hospital high volume diluted adrenaline infusion if patient is not responding to 3 doses of adrenaline. Wherever the place you need to, no matter whether you are in a field or wherever the place, you need to manage anaphylaxis then and there. That's why I told no, you don't have time to get your senior colleagues' opinion or all. If it is anaphylaxis, yes, you need to manage it then and there. Think if it is not anaphylaxis, what can happen? If your patient doesn't have an ischemic heart disease, what happens is with a single dose of adrenaline, their heart rate goes up and it may come down. With a single dose, they may go into, with an intramuscular dose, they may not going into dangerous cardiac arrhythmia. Single dose may cause only elevation of heart rate and it may come back. If you have a doubt, give adrenaline and save lives. If regarded suspicious patient, what is the next management? These patients should be directed to electrophysiologist. If you don't have electrophysiologist facilities in your hospital, direct them to cardiologist. Then cardiologist will do necessary echocardiogram, Holter monitoring, and then they will direct them to electrophysiologist. Refractory anaphylaxis, there are no first fluid, first adrenaline. Refractory anaphylaxis, you need to manage anaphylaxis in horizontal approach. You need to start fluid, you need to start adrenaline. You need to give fluid up to 50 ml per kg in half an hour's time, and if not responding, if your patient is not responding, you need to go for adrenaline infusion. Even with that, if patient is not responding, depending on patient's condition, if on beta blockers, you need to give glucagon and all, and even you can use metronidazole in refractory cases. Exactly how long it takes to act as steroid will take roughly about 3 to 4 hours to get maximum action. So for an emergency management of anaphylaxis, steroid is not the first line treatment. Adrenaline is the first line treatment. Still people are reluctant to give adrenaline. They have a fear of arrhythmia, but if no ischemic heart disease, you can give adrenaline to save patients' lives. One doctor has asked, is there a place for hydroxyethylene starch in management of sepsis? Clearly, no. Starches have no place in management of critically ill patient or critically bleeding patients. There are a lot of case reports and research has proven starches may lead into renal impairment and worse outcome. Hydroxy starches should not be used. Only situation where using starch is dengue shock patients if they are not responding to fluids. If we want to preserve fluid quota, we will give dextran. That is the only thing we are using in our practice. So I'll stop at this point, and if you have further questions, please email to me. I'll email you all. I'll post my email address on chat box. Finally, what I want to highlight here is a high degree of clinical suspicion is important before come to a final judgment. Always seek expert advice in case of doubt. I would like to give my special thanks to Government Medical Officers Association and staff of Sri Office and your patient participation of this presentation. So thank you very much.
Thank you very much, sir, for that informative presentation, and thank you for enlightening with our queries. And I would like to thank Dr. Tushara Vidanapatinna for his excellent presentation on behalf of GMOA and Sri Knowledge Academy.